I'd like to talk today about something that doesn't get discussed much in the field, and that is how much we give ourselves permission to kind of move quickly, to move efficiently with couples when they come in, versus we need to gather lots of information, have a big assessment, and then a game plan. And it occurs to me that this is like the difference between primary care in medicine and specialty care. And I come out of the primary care area. Some of it's my background in family therapy. You know, you have an acting out adolescent, the kid's running away from home. You got to start moving, okay? They come in, you got to take action. And also with couples, my sense is that, and there's evidence for this, that often you have one customer and the other's not so sure. Okay, so somebody's sort of, do I want to be here? Is this going to do any good? And that person may not want to hang around for a whole bunch of weeks. And then the third influence on me is my work with couples on the brink of divorce, where you have urgency now and you want some things to start moving, okay? So taking those together, it's helped me to think about it's helped me think about how in our field we can approach working with couples from like a family doc, seeing somebody with back pain who, you know, does a history, does a physical exam, rules out some things like there's numbness in your feet or something like that. And this is probably something that will resolve itself with some ibuprofen, with some time. And so doesn't do a huge workup, doesn't do an MRI, doesn't say, well, we're not going to do anything now until we get all the possible information, but says, it's probably this, let's proceed, stay in touch with me, and let's check back to see if we need to go another level. That's a primary care approach as opposed to a specialist approach where I have to have all the information, all the testing, which, by the way, may delay treatment for some time, even though you're in a lot of pain, until we know it all. Now, there's a place for both, but what I'm suggesting is that for many of the couples, most of the couples that come to us, we can start to help them change soon. We can take their primary complaint, we can see if we can help them shift some interaction pattern, and that we can fold assessment into the treatment, if you will, which is the primary care model, because you see, if it responds, the problem responds to ibuprofen, if it responds to rest. In other words, in the primary care way of thinking about this, the interventions, the safe interventions, are part of the assessment. You see how the patient responds. And I really think that this is a good way to approach couples therapy. Offer them something, offer them some observations, offer them some help soon within the first couple of sessions, rather than waiting a month, getting comprehensive assessment before we start to act. Now, I don't want to say there's anything wrong with that approach. There's evidence-based therapies that do that approach. And some therapists feel they really need to get lots of data before they intervene. Okay, I'm just saying, I don't believe that's necessary, and there's no evidence that it is necessary across the board, because there are other approaches to couples therapy that do not do it that way. So I'm just encouraging you to consider the primary care approach to couples therapy, where you don't have to know it all before you start to intervene, and that you see assessment and intervention as complementary and going along. And what this gives us is the advantage of moving more rapidly to help people. And my belief is that this often engages people. You get in sync with people because you are working with them for change early on, rather than the kind of specialist model that says, I have to know it all. Hope this helped.